Hello everyone. Now today's CME we will be talking about the vaginal cystic lesions as I had promised you about it. The thing is that I'm not going to cover all the vaginal masses or anything. We'll just talk about four common cystic lesions that we come across while doing a vaginal scan. And sometimes, since the positions are very close to each other, we get confused what it could be, and it is important that we differentiate. All of them are cystic lesions, all of them can get infected, all of them look very similar, but the management may be different for each one of them. So this is important for us to create a differential diagnosis as far as possible on ultrasound. Now, let us start with first the scanning part. What scanning would be helpful? Now, if you do a first, obviously, I always suggest that whenever you're doing a scan, always do a transabdominal first to get the idea, get oriented, and all those things. But yes, the differential diagnosis would be much better made with either transvaginal or translabial scanning. When you are doing translabial scanning, you can use a linear probe also, you can use a convex probe also. We all know what is translabial scanning. You have already been taught in the class what is translabial scanning, right? So let us now just go to the cysts one by one. Now, this is an important landmark that you can remember, which will help you differentiate different forms of cysts. For the cystic areas we are going to talk about: the Gartner's duct cyst, the urethral diverticulum, Skene gland cyst, and Bartholin cyst. So let us go one by one. Now, whenever you see a cystic lesion in the vaginal area, you can always go in for transvaginal or a translabial scan and see its location in relation to pubic symphysis. It will help you differentiate things, how we will see further. Whenever you see a vaginal cystic lesion, see whether they are superior to the pubic symphysis or inferior. I'll be showing you in ultrasound pictures how the pubic symphysis looks. If the cystic area in the vagina is lying superior, when you are doing a vaginal scan and you can see there is a cystic area, seeming sometimes like urethral diverticulum obviously is not a vaginal lesion, but since it would be in the similar position, we are talking about it. So if I see a cystic lesion superior to the pubic symphysis, so this is the pubic symphysis and this is the pelvic floor area. If I see a lesion superior, so that superior lesions can be what? They can be Gartner's duct cyst, which is in the upper vagina, or it could be a urethral diverticulum. So two things could be possible when we see a cystic area related to vaginal area on ultrasound. If it is superior to the pubic symphysis, it can be a Gartner's duct cyst or it can be a urethral diverticulum. How we will further differentiate, we will talk about it again. Gartner's duct cyst would be in the anterolateral wall of upper vagina, right? It would be in the anterolateral wall of upper vagina, and urethral diverticulum will be periurethral, the posterolateral margin of mid-urethra. But the problem is that when you are going to do the scan, both these lesions will look anterior, because since this is also on the anterolateral wall of vagina, it will be quite close to the urethra, as you will see in the ultrasound pictures further. So the confusion can come. But then what can help you differentiate? Urethral diverticulum will usually be in communication with the urethra. The word diverticulum itself is telling you that it would be in communication with the urethra, while this would not be communicating with the urethra. Then the lesions which are inferior to the pubic symphysis. So if I find there are lesions inferior to the pubic symphysis, what these can be? These can be either the Bartholin gland cyst or a Skene gland cyst, right? Now, how will you differentiate between the two? Again, the Skene gland cyst is in the anterior vaginal area, while Bartholin cyst is on the posterolateral margin. Little difficult because sometimes they may look very similar, but see if the lesion is looking closer to the urethral portion, it is likely a Skene gland cyst. If it is away from the urethral side, more towards the rectal side, then it is a Bartholin cyst. Right, so we talk about four lesions: Gartner duct cyst, urethral diverticulum, Skene gland cyst, and Bartholin cyst. And we take the landmark of pubic symphysis. If I find superior, Cystic lesions are superior to the pubic symphysis. That could be Gartner duct cysts or urethral diverticulum. If inferior, Skene gland cysts or Bartholin cysts. Bartholin cysts would be posterior, Skene gland cysts would be anterior. Gardner's duct cyst would also be anterior, but what is the difference? It would be above the pubic symphysis. And urethral diverticulum would be periurethral and may have communication and will have communication with the urethra. Picture wise, all of them will look anechoic, cystic, and if infected, then hypoechoic, right? Now, this is a picture showing you the relationships between bladder, vagina, urethra, and pubic symphysis on a translabial scan. How are you going to keep the probe? The probe has been kept longitudinally. Just like you keep it translabially, I've already told you how the probe has to be kept. So you keep it longitudinally. Translabial, we are obviously going to do with the convex probe or the linear probe. So this side would be representing superior and this side would be representing inferior when we take a longitudinal scan like it is in the abdominal view. Now, this is the picture how pubic symphysis will look, like a bright linear area and some shadow, and looks like a conical portion. This is a typical picture of pubic symphysis. So you see pubic symphysis here, and next to it, obviously, the bladder is seen, which is slightly kept full. This is the urethral area. You can make out in the gland diagram also. This is the urethral area. This is the bladder neck area. And then we have the vaginal area. This is the vagina. And then the rectal area is there behind the vagina, the anal canal and all. So you can see shadows and bright areas. What we are seeing, the pubic symphysis, then the urethra, then the vagina, and then the rectal area is seen there. Behind the vagina. So this picture can help you, and this is the picture. This is the thing that you should remember, how pubic symphysis appears. The same picture would come in transvaginal scan, no difference as such, right? Now let us go further. This picture, let us analyze this lesion. First of all, here is the pubic symphysis, right? It is a longitudinal scan. So when we see pubic symphysis here in a longitudinal scan, which means this is inferior side, this is superior side. So this cystic lesion we are finding is superior to the pubic symphysis, right? Then what we notice that it is seen in the anterior portion. How do we judge it as anterior portion? It's closer to the bladder. So we can come to know that this is in the anterior side. So, right, transvaginally we can judge the anterior by seeing the bladder. So this comes closer to the bladder, superior to the pubic symphysis. So this is a Gartner's duct cyst, right? If you go back to that slide, Gartner's duct cyst, superior to the pubic symphysis and in the anterolateral wall of upper vagina. Now, so this is one of the most common lesions. It is a remnant of a distal mesonephric duct. Usually it is asymptomatic but can be associated with other urogenital anomalies like ectopic ureters, unilateral renal agenesis or hypoplasia. My main purpose of this lecture is just to help you differentiate between the different lesions ultrasonologically. Now, urethral diverticulum, the second lesion we talked about. What did we say? This would be superior to the pubic symphysis. So yes, this would again be superior to pubic symphysis, and it would be periurethral. It will communicate with the urethra. So what we see here, pubic symphysis, although not very clearly seen in this picture, but it is somewhere here labeled. This is the urethra. This is that cystic area close to the urethra, and we can see another one, and it is communicating with the urethra. This one is not looking anechoic. Why? Because this is infected and has changed into a pus-filled area. So there is the echoic areas echoes you can see inside, and this is a urethral diverticulum. Right. The bladder is here collapsed. It is not filled properly. Then same picture here. We can see the pubic symphysis has been labeled here. These are the cystic areas close to the urethra. Communication, this one is seen, this one is not very clear here. And again, these are urethral diverticulum. So periurethral, they communicate with the urethral lumen. Obviously, since they are forming pouches, the urine can collect in them and that can lead to UTI. It can also lead to dysuria, dribbling after voiding, and dyspareunia. This is the triad with which usually the urethral diverticulum patients come. No, 3Ds: dysuria, dribbling, dyspareunia. There may be a painful mass along the anterior vaginal wall. Diverticular neck may be wide or narrow. It is difficult to see on many times on ultrasound, and can be, but transvaginally most of the time you will be able to make out the communication, and can be, obviously we know that whenever there is a diverticulum, urine stasis will occur. There can be stone formation, infection, and rarely malignant transformation. Right, so superior to pubic symphysis, periurethral, often the communication with urethra will be seen. Then comes the two other lesions which are inferior to the pubic symphysis, the Skene gland cyst and the Bartholin duct cyst. Both are inferior to the pubic symphysis. The Skene gland cyst anterior and Bartholin cyst posterior. The picture again, let us see the picture here. This is the pubic symphysis. Longitudinal scan, this is the superior area. Pubic symphysis is superior. The cystic lesion that we are seeing filled with internal echos, likely infected. So this is the area that we are seeing, inferior to the pubic symphysis, but it is seen very close to the urethra. So that means it is in the anterior vaginal wall. No? If you go back to the previous picture, can you see? This is the urethra, and the anterior vaginal wall would be next to the urethra. So it is more closer to the bladder. So we come back to this. This is the Skene gland cyst, and it is not showing any communication with the urethra. Now, the confusion could have come between Skene gland cyst and urethral diverticulum, right? Because both are very close to the urethra. But what is the difference? The difference is this one would be inferior to the pubic symphysis, and this one would be superior to the pubic symphysis. And remember, for inferior superior you have to keep your probe longitudinally. Then the Bartholin gland cyst. Now let us see the picture here. This is the vaginal area that is being shown. The vaginal mucosa is bright. In this case you are not seeing any pubic symphysis or anything. We are just seeing the cystic lesion is there. And again, what we do is we put the probe longitudinally. You can see the pubic symphysis somewhere here in the longitudinal scan, and the lesion is where? Inferior to the pubic symphysis, right? A cystic lesion inferior to the pubic symphysis in the posterior vaginal wall, so that is likely a Bartholin gland cyst, right? Bartholin glands arise from the urogenital sinus. They are paired, and Bartholin cysts may form due to ductal obstruction, superinfection, and abscess formation. They are common. Malignant change may be there. These are just additional things. Skene glands, also known as the periurethral glands, are paired along the distal urethra. They are female analog. They are considered as female analog to the male prostate, and the cysts form in one of these glands extending along the external urethral orifice. They can get infected and may even cause urethral obstruction when they are large. Like in this case also, you can see the urethra is collapsed in this area, which is showing you that there is an obstruction, likely because of this Skene gland enlargement and infection. Fine. So this is how you can differentiate all the four cystic lesions, which are which are the common ones that you come across when you are looking for vaginal cysts. And this is again summarizing the whole thing. If I see a cystic lesion in the vaginal area, I can just locate it in relation to pubic symphysis. If it is superior to pubic symphysis, then I look whether it is in the anterior vaginal wall or it is periurethral and communicating with the urethra. Maybe communication may sometimes not be seen, but try doing it a TVS. You will be able to see many times. In the anterior vaginal wall, it is Gartner cyst. Periurethral, it is urethral diverticulum. If the lesion is inferior to the pubic symphysis, whether it is anterior or posterior. In the anterior vaginal wall, which means it will be more towards the urethra, more closer to the bladder, then it is a Skene gland cyst. And if it is in the posterior side towards the rectal side more, then it is a Bartholin gland cyst. Right, so this can help you differentiate between the different vaginal cystic lesions. I have not taken up all the masses related to vagina, or I have not talked about cystocele and rectocele. Maybe some other time I'll take a small topic related to that. But right for now, we just talk about these four cystic lesions and how to differentiate between them, and knowing the importance of pubic symphysis, which can help us in differential diagnosis. So I hope this would be helpful for you all. And whenever you are seeing a cystic lesion in the vagina, you will be able to differentiate it more clearly. Thank you very much.